In this video, I'll be discussing the pathophysiology and the pharmacology associated with Parkinson's disease. The pathophysiology of Parkinson's disease is quite complex, involving numerous neural pathways or processes that are not quite fully understood yet. However, evidence does suggest that the primary pathophysiology of Parkinson's disease starts with the aggregation of alpha-synuclein proteins inside brain cells, which we call neurons, and this occurs primarily in the neurons of the substantia nigra. It is unclear what causes this accumulation of proteins. However, studies have found links to genetic mutations, environmental agents, and gut microbiota, which are still under active research. The accumulation of alpha-synuclein proteins form Lewy bodies in these neurons, which ultimately causes cell degeneration and cell death. The substantia nigra is a region of the brain found in the basal ganglia and is responsible for the production of dopamine. Dopamine is released by the neurons of the substantia nigra and transported to the striatum via the nigrostriatal pathway, which are all situated in the basal ganglia. So when there is cell degeneration or death, these neurons are not able to carry out their normal functions, which of course is the release of dopamine. Consequently, this results in a reduction of dopamine in the basal ganglia. And this depletion of dopamine is what ultimately results in suppressed movement, which we'll explore further in the next slide. So the basal ganglia is basically an umbrella term for the group of subcortical nuclei responsible for motor control, including the control of support, posture, and voluntary movement. And they depend on dopamine for this. So the role of dopamine in this structure is to regulate the balance between the excitatory and inhibitory neural motor pathways. When there is a depletion of dopamine, these balances are disturbed, causing increased inhibition of the thalamus, which is the indirect pathway, and decreased excitatory input to the motor cortex, which is the direct pathway. The indirect pathway is responsible for inhibiting motor movement, while the direct pathway is responsible for allowing motor movement. Thus, the overactivity of the indirect pathway combined with the hypoactivity or reduced activity of the direct pathway results in suppressed movement, and this is what causes the cardinal manifestations of Parkinson's disease, including tremor, rigidity, bradykinesia, and postural instability. Now, although Parkinson's disease cannot be cured, there are medications that can be effective in controlling the motor symptoms or manifestations that I mentioned in the previous slide. One medication that is commonly used to manage Parkinson's disease is levodopa-carbidopa. Levodopa-carbidopa is actually the first-line therapy used in most patients as it is considered the most effective. Levodopa is classed as a dopamine precursor, while carbidopa is known as a decarboxylase inhibitor. The reason levodopa is used in the treatment of Parkinson's is because it converts to dopamine in the brain. On the other hand, carbidopa prevents the absorption of levodopa in the peripheral nervous system, so more can reach the central nervous system. As a result, this increases levodopa's bioavailability and actually reduces some of its side effects. Now, the reason dopamine's precursor is given and not dopamine itself is because levodopa is able to cross the blood-brain barrier while dopamine cannot. Again, just to reiterate, levodopa converts to dopamine in the central nervous system. Once it converts, it stimulates the postsynaptic dopaminergic receptors and recompensates for the loss of dopamine. Again, we know that the characteristic motor symptoms of Parkinson's occur due to a depletion of dopamine in the brain. Thus, levodopa can help to alleviate and improve these symptoms by increasing dopamine levels in the brain. In saying this, Emma, the patient who I've discussed in my website, would benefit from the use of this medication to help manage her motor symptoms. In the next slides, we'll discuss other considerations for this medication. So, levodopa-carbidopa, or just levodopa, is contraindicated in patients who use monoamine oxidase inhibitors, which must be discontinued for at least 2 weeks before the administration of levodopa. Also, patients with known hypersensitivity to the drug, narrow angle glaucoma, or suspicious undiagnosed skin lesions or history of melanoma, and this is because levodopa can actually activate a malignant melanoma. Common adverse effects seen in patients taking levodopa-carbidopa include nausea, dyskinesia, which is involuntary movement of the face, arms, legs, or trunk, mental changes, including paranoid ideation and psychotic episodes, which may manifest as delusions, hallucinations, depression, or suicidal tendencies. In saying this, it's important to monitor your patients closely for adverse effects and report them to the treating doctors, as this may indicate the need for a dosage reduction or even a change of medication. So, levodopa-carbidopa usually comes in the form of uncoated tablets for oral administration. And as long as these tablets do not specify modified release, they may be crushed or dispersed in water. It is recommended that levodopa-carbidopa is administered 3 times a day with a daily maximum dose of 2 grams of levodopa and 200 milligrams of carbidopa. It's important to be aware of these guidelines before administering this drug, as any orders that go against these recommendations should be followed up with the treating doctors to prevent and reduce the risk of adverse effects. Also, storage requirements recommend that this medication is stored below 25 degrees Celsius, is protected from light and moisture, and is kept tightly in a closed container. And that is the end of my presentation. Thank you for listening.